Hi, I'm Dr. Kathleen Janel. If you haven't seen my work before, I talk a lot about sulfur, and I talk a lot about the way sulfur impacts to heal and create better motility and resolve gasiness and bloating in the digestive system. Sulfur is a mineral. It's an element. It's a singular standalone, and it's necessary for our health. This is my company, GIJanel.com, and you can find all of your resources there, including doctors that I've trained in this system so that they can help you with your SIBO and your IBS. So where all this began was about 25, 30 years ago when I started using this protocol for gas and bloating. And back in those days, SIBO wasn't really very well known. And so for the most part, we thought when people were having gas and bloating symptoms, it was more of a yeast problem, which in some ways it still is. So I started using this protocol for people who had candida as an antifungal to stop their gas and bloating symptoms, and it worked great. So I started using it pretty much all of my digestive patients in some form. And what I found over time was that if I adjusted the dosing, I could also get improvements in constipation, chronic constipation for my patients, and for diarrhea. I'm talking about inflammatory diarrhea, motility issues there for people who have either some kind of microscopic colitis, other colitis, acute colitis, and inflammatory bowel disease. I've been in practice for 27 years now, and I've treated thousands of patients all over the world with this sulfur protocol, and focusing on the categories of IBS, irritable bowel syndrome, intestinal microbial overgrowth, that's bacterial overgrowth in the small or the large intestine, and intestinal fungal overgrowth. That's overgrowth of fungal species or yeast species in the large and small intestine. The places around the world where I've treated people so far are in this list, and that's been just an amazing event for me to be able to have people reach out from all over the world and to be able to actually help them with this natural treatment to resolve their symptoms. The doctors that I've trained are across the US and Canada. That number is growing, and again, that list is on my website. So if you're looking for a local practitioner who uses the GI Janel One powder and the GI Janel protocol, then that's the place to look to find someone close to you. So first of all, I'm going to go into a lot of overview of MSM, methylsulfonomethane, which is the main component of sulfur that's in my formula. And MSM is an organosulfur compound, and it's found in a lot of foods, including milk or milk products, grains, and then fruits and vegetables. So as the MSM form, it's found in those foods. And there's evidence that indicates that it can act as a dietary source of sulfur to affect the compartmentalization and metabolism of sulfur compounds via the digestive microbial species. So that I just said a lot. Let me break that down. Methylsulfonomethane itself cannot feed directly into the sulfur cycles, and the sulfur cycles includes that list that I've got here: NAC, glutathione, S-adenosylmethionine, cysteine, taurine, methionine, homocysteine, cystathione, coenzyme A, hypotaurine, and taurine. So that's your sulfur cycle that's cycling through you all the time, and MSM can't feed into that directly, but your microbial species in your gut is what we think can switch the MSM form of sulfur into methionine so it can feed into that cycle. So there's studies that have shown that via the PAPS mechanism, and that's still theoretical at this point. Sulfur plays an essential role in many physiological processes, including the synthesis of collagen. We'll get into that in a little bit, but collagen requires sulfur to reform it. You can make collagen in your body if you have the right components. Sulfur is one of them. MSM may also help protect the extracellular matrix proteins from damage and degradation by attenuating inflammation and reducing oxidative stress. So there's a lot on this slide. I'm going to break it all down as we go through this. Here's the inflammation part of methylsulfonylmethane. So it's able to inhibit these pro-inflammatory cytokines. And these are some of the things that get targeted as biologic drugs right now, things that block these cytokines specifically for people who have like inflammatory bowel disease or rheumatoid arthritis or psoriasis. So these are interleukin 1, interleukin 6, tumor necrosis factor alpha, prostaglandin E2, and nuclear factor kappa beta. And methylsulfonylmethane can support the body's intrinsic antioxidants as well. So anti-inflammation, antioxidant. And it can do that, again, from what I said earlier, once it feeds into the sulfur cycles and forms glutathione, superoxide dismutase, and catalase. It's also been shown to reduce the levels of homocysteine. So homocysteine is a molecule that can damage collagen cross-linking, and that collagen cross-linking, of course, is essential for the elasticity of our epithelial tissue. Epithelium is the lining tissue, lines the gut. I'm going to jump right into a case so that you guys can see how well this works and how quickly this works. So this is a motility case, and we're going to first look at slow motility or constipation. So this is a very classic presentation. I see this all the time in my practice. In fact, the majority of people I'm seeing right now are people who have been diagnosed with SIBO and have gone through years and years of treatment, but still really aren't better. This particular woman is 60 years old, and she was diagnosed between 2018 and 2023 with SIBO. So she'd had many SIBO tests. She'd had 4 courses of rifaximin, which is the antibiotic that's recommended. She had erythromycin, metronidazole, more antibiotics, herbal antimicrobials, and other motility treatments, both prescription and natural. And what her response was, she has less and less improvement over time, and then everything would come back. Now, this is interesting because if you do a SIBO test, you're targeting literally 2 different species depending on what comes up. We know that from some of the work that's been done to correlate the species that are fermenting in the gut, producing gas. So if you get less and less improvement over time with the same treatment for the same bacteria, then that doesn't really make sense to me. Because if you've really targeted those bacteria, it should work better and eventually be gone. So we might not be focused on the right thing here. So I saw her in 2023. These were her symptoms. She had constipation that was so severe, she had to use a triple dose of Miralax every day. She was having abdominal pain. She was having bloating. All I did was have her titrate up the GI Janel One powder, Sulfur protocol, and had her hold that GI One powder for 8 weeks at the full dose. And then we talked. When we talked again, she told me she was off Miralax. She was having regular bowel movements. Her bloating and her pain were resolved. So that was just over 2 years ago now. I just last saw her in January of 2025. So that resolved her symptoms and has kept them resolved for over 2 years. And by my experience, she's done with this recurring symptom. Here's another motility case, and this is somebody overseas, I think somewhere in Europe. And she had a little bit of problems at first with the GI One powder because there can be some adjustments at first. But here's her story. Hi, I just started week 5 of your protocol for treating IBS-C, which is irritable bowel syndrome constipation. At least that's what my MD gave me as a diagnosis. I've followed your Sulfur, GI One powder protocol, magnesium, and AMBM, which is another supplement I have for motility for the first 3 weeks at the full dose. It was rough. I had worsening gas and bloating. This is normal. This often happens, and that's why you want to be working with a doctor who can manage that for you, with you, to bring you success in the end. Then something changed. I started to feel better around week 10. Feel better about 10 days ago. Gas and bloating declined, and today at week 5 is minimal, if at all. I have also been very regular, sometimes going twice a day, whereas before I started this, I had no urge to go, and I was doing daily enemas. I'm beyond thrilled, to say the least, and she's appreciative and grateful that she finally feels normal. And again, in my experience, 99.9% of the time, once she's finished with this, she's done, the GI symptoms will be gone. And depending on her age, she might need to take a little bit of extra magnesium to keep her bowels moving, but that's it. No medications, no regression of symptoms. So what we're going to do right now is talk through the therapeutic steps for motility on the constipation or slow motility aspect. What I'm going to do for everybody is I'm going to remove their inflammatory foods as necessary. And those inflammatory foods are going to be cow dairy, wheat, whole eggs, soy, and sugar. Now, this is important if I'm working with somebody who's like overseas or in another part of the country that might not have the same acumen about inflammatory foods that local people do in Washington State, because there's so many naturopaths here and so much information out there about these foods. So it's not absolutely necessary to remove these foods. A lot of people who I'm seeing now have already done it. They're already off all of these inflammatory foods. Their symptoms persist. So I know that the inflammatory foods are not a part of their problem, but I'm going to use those foods in the end, once they're better, to do a challenge to see if those foods still bother them. So wait until the slate is clear and then test those foods. So stay off them if you're already off them. Then what I'm going to do is I'm going to initiate the therapeutic steps, and I'm going to start the sulfur therapy in one of two ways. So if I've got a very sensitive patient, someone who's been through multiple courses of Xifaxan, rifaximin, someone who's just now they're reactive to everything, probably because they've been having so much antibiotic exposure, then I'm going to start them with a very small dose. I'm just going to use a pinch. Right? They're just going to do a pinch in water every day and gradually increase that dose. Someone who's stronger and maybe hasn't had their symptoms for so long or hasn't been overtreated, I'm going to give them more like a 0.5 teaspoon, which is the equivalent of 2.5 grams a day of the GI One powder. I'm going to make sure I assure them that they can have a Herx type die-off reaction or sulfur cycle upregulation reaction. So you can feel flu-like when you're killing bacteria and yeast in your body. You can have sulfur upregulation symptoms, like some people might have a rash that's temporary or get a headache or feel like they're not sleeping as well. Those things all subside over time, and they're actually good. It's good that you're having a Herx reaction because you're killing the stuff you want to get rid of in your body, and it's getting flushed out. It's good that you're having sulfur cycle upregulation because obviously the system is very deficient in sulfur and it needs to be replenished. We'll get into sulfur requirements in the body later. Third thing I'm going to do is assure my patients that gas may continue to pass as bloating subsides. And it might even increase a little bit, right? It's like the balloon is deflating. We're getting rid of the bloating by removing it from the body, and eventually that all gets better too. I want to usually follow up in 2 weeks to just manage any kind of either sulfur cycle upregulation or die-off reactions or increase in symptoms that might potentially happen in the early part of the treatment. Then I'm going to have them gradually increase their sulfur dose to the 6 heaping teaspoons, which is the equivalent of 2 heaping tablespoons and is also the equivalent of 30 grams per day of the GI One powder. They're going to hold this dose for 8 weeks once they get to that full dose. After the 8 weeks, I'm going to have them step down to a maintenance dose, and that's usually decreased by 1 teaspoon a week until you're at somewhere between 0.5 and 1 teaspoon, which is the equivalent of 2.5 to 5 grams a day. And the reason I'm doing that is because I want to keep that motility that we've achieved going. I want to keep making sure that they get adequate amounts of sulfur. Our requirement is 850 to 1500 milligrams a day. It's essential for us. So I just want to make sure that they stay on a maintenance dose to keep those cycles active. And then I'm going to work with foods. So then I'm going to gradually reintroduce foods as prebiotics to help stimulate the colonic diversity. You get way more colonic diversity from prebiotic foods than you do from uphill. So I'm going to do this in 2 different groups. I'm going to use the FODMAP foods like cooked cruciferous and allium family foods and legumes, and I'm going to give people tiny bits of that every day, tiny bits of those foods every day, so their colonic diversity upregulates and they have the right bacteria living inside them to help them digest those foods without a lot of problems. So gradual reintroduction of those foods very slowly until you don't have to think about it anymore. And then with the inflammatory foods, that group of 5 that I just showed you, dairy, wheat, eggs, sugar, and soy, what I'm going to do is an elimination challenge. They've already eliminated it, so we're going to do a challenge. We're going to eat the food, wait for 2 days, and track any kind of symptoms, because there can be a delayed reaction with those inflammatory foods, and you don't want to miss it, and you don't want to try a second food too soon thinking that the response is coming from the second food when really it's coming from the first food. So wait for 48 hours after trying one of those foods. Do some recording of any symptoms for yourself so you can remember, and then try the remainder of the foods one at a time, leaving a space of 2 days between. So let's look at what might be happening here. Here's a proposed mechanism for MSM improving motility in constipation. In this study, what they did was they took rats and they damaged their neurons. They did some neurodegenerative induced damage with BPA and with radiation, and what they were trying to do was put them in a place where they had a brain that looked like Alzheimer's disorder, and then do some testing from there. But what they noticed was if they gave methylsulfonomethane at the same time as they were doing this neurodegenerative damage, the effects of that damage were less because of the antioxidant, anti-inflammatory properties and inhibition of acetylcholine esterase. So the acetylcholine esterase is what I want to focus on because that's a neurotransmitter, right? That is important in the gut. Here's the schematic of what they did. So up top, we've got where the ionizing radiation and the BPA were causing these neuroinflammation and oxidative stress changes within the brain. And here's our MSM. So whenever you see one of these little green bars, and it's showing what MSM is mitigating in this process, let's hop over to acetylcholine esterase activity. So the neurodegeneration is increasing acetylcholine esterase activity. Acetylcholine esterase breaks down acetylcholine, so it makes less acetylcholine. What the MSM does is protect that or prevent that so that you do not get a decrease in acetylcholine esterase activity. That means you have more available acetylcholine because it's not being broken down by that enzyme. What does acetylcholine do in the gut? When acetylcholine binds to muscarinic receptors, it moves food through the intestine by contracting intestinal muscles and increasing stomach and intestinal secretions. It also causes the supportive digestive glands, like the pancreas, to secrete their digestive substances. So here's a proposed mechanism for how methylsulfonomethane in the GI1 powder is helping people with their chronic constipation symptoms. Now let's hop over to the other end of the spectrum, inflammatory diarrhea. So again, this can be acute onset gastroenteritis, food poisoning. It can be microscopic colitis, something that happens to women primarily over 50. They suddenly just get this inflammatory diarrhea that just came out of nowhere and won't stop, and there's not a lot of treatments for it out there besides steroids. And then also ulcerative colitis or inflammatory bowel disease. This particular case is a 40-year-old woman who had ulcerative colitis, and it had been going on for 15 years. And she had already failed 3 of the biologics. She had tried and failed Remicade, Humira, and when I saw her, she was flaring on Entyvio, waiting to see if she could get put onto Skyrizi, which is one of the newest biologics. And just to backtrack a little bit, remember that list of inflammatory cytokines that I showed you? That's what the biologics are targeting. They're targeting those places where inflammation happens specifically for these people who have this kind of inflammation. So I saw her and started her on the GI One protocol, 2.5 grams a week, and had her titrate up to 15 grams a day. And then I saw her, last time was in February of 2025, and at that 15 gram dose, which is a little high than I normally use, but that seems to be what worked for her. She told me that this is someone with ulcerative colitis who has failed 3 biologics so far. She was having 2 bowel movements a day. She stopped waking at night with gas, blood, and mucus passing in her stools. Her bloating had resolved, both lower and mid-abdomen, and her gas, flatulence, and burping had improved. So I've been treating inflammatory bowel for 27 years, and this is one of the best resolutions that I've ever had. And also, when I use this with my inflammatory bowel disease patients, apart from anything else I've ever tried, it really does work. Not 100% of the time, but it does work very well when it works. Here is a case of acute viral gastroenteritis. So this is a person who has a chronic sequelae. So what happened was in September of 2024, she got the norovirus, and she started to get GI symptoms that didn't go away. Once she got the norovirus, she started having these symptoms she's never had before, and they just perpetuated and continued. She'd been to gastroenterology. She's been to her primary care provider, and no one could figure out what was happening. She had all the tests. She didn't have any norovirus left in her system, and there was nothing else to indicate that these symptoms should be chronic. What she told me was that she was having severe abdominal pain, and it felt like an obstruction. It felt like things weren't moving. But she was also having diarrhea several times a day, and she was seeing digestive tissue and blood in her toilet. So when I saw her in December of 2024, what I did was, her diet was already really clean, so I put her on the GI One protocol for inflammation at 5 grams a day. That's 1 teaspoon a day. And then I followed up with her a month later, and she told me she was having 1 to 2 bowel movements a day that were formed. She was no longer having bleeding. Her abdominal pain had resolved, and also the residual achiness from previous symptoms had resolved. And that's one thing I find, is that someone who has had months, years of abdominal pain, they go through this period of time once it's resolved where they're just really tender. The pain is gone, but it's just really tender in the system, which makes sense because that system has been gone through a lot. So let's talk now about the therapeutic steps that I use for motility on the inflammatory or diarrhea end of the spectrum. Very simply, I'll initiate the sulfur therapy at 2.5 grams a day. And then I will increase that usually only to 5 grams a day. That's 1 full teaspoon. So first week they're going to do 2.5 grams, second week they're going to do 5 grams, and then in 2 to 4 weeks I will do a follow-up visit with them to determine if we need to increase or decrease that dose. So simple. What we're going to talk about in this lecture is the way that the GI One powder works to repair and protect our bodies. We also know that it's antimicrobial, it's also antifungal, and that's where this whole thing started for me years ago. But I've given many other lectures on that aspect, so you can find those on my socials. So structure and repair using GI One powder. Let's remember that when you break down the elemental composition of the human body, sulfur is the 4th most common mineral, right? So we've got calcium, we've got phosphorus, we've got potassium, and then we've got sulfur. In fact, we've got twice as much sulfur in our bodies as we have magnesium, 0.1%, 0.2% in our body. And sulfur is essential. We can't make it. We have to take it in every day. What sulfur does at the microscopic level is it forms bonds with itself. And when you have a small amount of these bonds within a system, you're going to have elasticity, you're going to have stretch and recoil. It's going to give you that elastic effect. That's motility, right? And what is exemplified here by is gluten. Gluten has sulfur in it, and that's what, when you make a dough and it's in that stage where it's all gooey and stretchy, that's the sulfur bonds in the gluten molecule acting. And that's why it's so hard to mimic bread when you use a gluten-free bread, because it's missing that stretchy, gooey component. So they add in a bunch of gums and stuff, and that can upset some people's stomach too. When you have a high sulfur content, like in your hair or your nails, have a very high sulfur content. In fact, there's much more sulfur in your nails than there is calcium. The sulfur acting with the keratin is what's making the strength. So you're getting strength from the sulfur bonds when you have a lot of sulfur. When you have a little bit of sulfur, you're getting more principles of elastic recoil. So I'm going to talk a little bit about protein structure right now, and you can skip over this part if you want to. This is more if you're really interested in the deep dive here. So the primary protein structure is the sequence of amino acids, right? Over here, that's circled. You've got glycine, phenylalanine, gluten, blah, blah, blah. So that's a linear structure. That's the way it comes off the ribosome as programmed by the DNA. Primary structure of proteins. Secondary structure of proteins is when the side groups of those individual amino acids start to interact with each other and form the alpha helix and the beta pleated sheet. So still a pretty loose structure. Tertiary structure is when the side groups start to interact more strongly in terms of chemical bonds, ionic, covalent, and hydrogen bonds. So that's going to hold that protein in its 3-dimensional shape. So can you see that sulfur is actually, you're going to see that sulfur is actually responsible for the 3-dimensional shape of the proteins in your body. If we look at the different forms of these bonds that hold proteins together from weaker to stronger, the weakest ones are called van der forces. They're literally clouds of electrons that attract and disperse. So they're very temporary, very weak. The second most common is the hydrogen bond, and that is a pulling of the electronegative force from the hydrogen to the oxygen. Again, it's a very weak force. The third most strong bonding in the protein structure is an ionic bond. Now, in pure chemistry, an ionic bond is stronger than a covalent bond. But in a biologic solution, which means something that's in water, we're like a bag of water, and our blood is water-based. So in a biological system, the covalent bond is actually stronger. The ionic bond is a donated electron, right? One atom takes that electron from the other one, and it will dissociate in water. Just put salt in water, and you can notice that. The covalent bond is the strongest bond in a biological system, and the majority of these bonds in your proteins by far is the sulfur bond. So the sulfur bonds are the strongest bonds that contribute to three-dimensional structure in proteins. They're the covalent linkages between the sulfur-containing side chains of the amino acid cysteine. And they act like molecular safety pins, keeping the parts of that polypeptide, which is another word for protein, firmly attached to one another. So one more time, if you have a large amount of these sulfur bonds in your protein structure, you're going to get principles of strength and hardness, along with flexibility, strength, and hardness. When you have a smaller amount of these, you're going to get the principles of elasticity. Where are you going to find that? One of the places is in the digestive system, right? Also your skin, but digestive system, elasticity, stretch, and recoil. So just revisiting this one more time, elasticity, like what you get from the sulfur bonds in gluten when you're making dough. And if you have a lot more of this disulfide bonding interacting with alpha carotene, you're going to get something as strong as a tortoise shell. The mechanical properties of tensile strength, elasticity, viscosity, and hardness all correlate with the degree of disulfide bonding. Here's the chemical formula for making a sulfur bond. You're taking two cysteine amino acids. They're going to interact through the sulfhydryl group. You're going to get a reduction reaction, losing two hydrogens and two electrons, and that is going to allow the two sulfur moieties to bind together, creating that disulfide, two sulfur disulfide bond. So let's now expand out our view and take a look at how this sulfur is going to interact with the place that we're focused on, which is the GI barrier structure, right? Where does sulfur come into play here? The epithelial and endothelial cells, which are the lining cells of your body, are going to use these barrier glycosaminoglycans for their structural integrity, right? And it's going to show up in the basement membrane and in the connections between cells. And the glycosaminoglycans that we're talking about are hydrogen sulfate, chondroitin sulfate, and dermatan sulfate, right? They're all sulfated. Remember back to, again, here's all of the glycosaminoglycans, or they're also called mucopolysaccharides. We've got a bunch of them here. So what we're seeing here is that each of these different glycosaminoglycans, chondroitin, heparin, keratin, and hyaluronic acid, one of the other things they do is they connect to core proteins in the cell membrane. So here's the cell membrane, here's the extracellular matrix, and what we used to think was this was a hydration proposal, that they were holding in water to keep things moist. They're doing a lot more than that. There's a lot more cell signaling going on. And the only mucopolysaccharide that does not have sulfur is hyaluronic acid. And I want to tell you something about that. Look at the size of this thing. It's the green one. It really goes across the whole screen, right? And that's a schematic, but it's accurate. Hyaluronic acid is a huge molecule. And if you put it on your skin, it's never going to get through. It's trying to get an elephant through a keyhole. So these products that have hyaluronic acid in them, think twice about that. A lot of times what we do is we hydrolyze these proteins, we break them down, but then you're not really getting the hyaluronic acid. You're expecting your body to reform it if it gets absorbed inside. That's a maybe. A lot of words here. Glycosaminoglycans, which are also known as mucopolysaccharides, are negatively charged polysaccharide compounds. They're composed of repeating disaccharide units, and they're present in every mammalian tissue, right? So negatively charged repeating disaccharide units. That negative charge is important. That means polyionic and ionic, which is going to be able to hold water in it. Their functions in the body are widespread, and historically, we thought the functions of these gags was limited to cell hydration and scaffolding. But now we know that gags actually play a key role in cell signaling and modulation of biological processes. Some of these processes are going to include cell growth and proliferation, promoting cell adhesion, anticoagulation, and wound repair. And we've already covered the fact that the 4 primary groups of glycosaminoglycans are based on the core disaccharide units, but they all have sulfur. And it's heparin sulfate, chondroitin sulfate, dermatan sulfate, keratin sulfate. Hyaluronic acid is the outlier. So now let's look at collagen, because collagen's really big right now. So collagen fibers all have disulfide bonds in the middle of them to hold together that triple helix structure. They're embedded in a web of these glycosaminoglycan complexes that we just looked at. And we know that the majority of those are sulfonated. And we know that the gags are a chain of disaccharides that is linked to a polypeptide core. There's your sulfur proteins. And they connect the fibers together that provide the force to hold together that collagen itself. The type of collagen we're talking about for our interests are type 4 collagen, the basement membrane type collagen primarily, which is a 2-dimensional network in the basal lamina. Type 4 collagen, the basement membrane collagen, is laminin, heparin sulfate, proteoglycan, and fibronectin connected to the basal lamina of the basement membranes. So collagen powder, this is fascinating to me. The majority of collagen powders that we use are hydrolyzed, right? So let's go through the steps. You've got your whole collagen here, and then you denature it to get gelatin. That's like when you cook a whole chicken and then you put it in the fridge and you get that jelly stuff. That's the gelatin, that's denatured collagen. You just made yourself a supplement. It's healthy to eat that, and it's also has immune stimulating properties if you boil the bones afterwards. Then it's degraded into peptides, so the small building blocks of proteins, peptides, but we can't absorb it like that in our gut, so it's hydrolyzed after that into individual amino acids. So now what you're expecting to do is you're expecting your body, once you absorb these, to reform it back into collagen, right? That's what you're after in the long run. But in order to do that, you require sulfur. So if you're not taking sulfur with your collagen, hydrolyzed collagen powder, and you have a deficit of it in your body, you're not going to be able to reform collagen. And we can make collagen on our own. We don't have to take it in. It's not essential. So does the hydrolyzed collagen powder contain sulfur? No. The collagen fibers in animals contain disulfide bonds, creating their distinct triple helix structure. When collagen is hydrolyzed, the sulfur ions are released. One more visit to glycosaminoglycans. They're a vital component of the epithelium and all of our connective tissues. They're found in the extracellular matrix, and on cell surfaces, they're polyanionic molecules that hold water and positively charged ions. And their functions include creating elasticity. They support collagen production and connective tissue elasticity. Cell signaling, hydration, growth factors and exosomes are allowed to move through them in the extracellular matrix, so they guide these things through. And they form the basement membrane of glycosaminoglycans when you're talking about chondroitin, dermatan, and heparin sulfate. And they're also important for cellular adhesion. What I want to do now is make sure that we understand what linings we're talking about in the body, right? So there's epithelium, which is lining the outer surfaces. There's endothelium that lines the interior surface of blood vessels and the lymphatic system. They have two different embryonic origins. Epithelium lining the gut and the skin. It's not lining the skin, it's on the outer surface of the skin and the gut. And it comes from ectoderm and endoderm. We have 3 cell layers when we're in our embryology state, right? We're dividing. We have 3 cell layers: epitherm, ectoderm, endoderm, and mesoderm. So epithelium, that outer lining of the gut and the skin, is coming from ectoderm and endoderm. And endothelium is coming from mesoderm. And this is something that you really see if you're involved in oncology, because cancers are going to arise from those more primordial tissue layers. So you can have a mesodermal type of cancer or a cancer that's ectodermal or endodermal, and they behave very differently and they're treated very differently. And the reason I'm getting into this is because a lot of the upcoming studies I'm going to show you are based on skin, but I want you to remember that the skin, the outer lining of your body, is basically the same origin tissue as the inner lining of your digestive system, right? It's continuous on either end with the outside. And really the main difference is that your skin is thicker. Your gut barrier is literally 1 cell layer thick, so it can bring nutrients across. So here's a study that was done on dermal density, and what they did was they took a high-dose collagen in one group, 10 grams of collagen plus vitamin C, and then in another group they took a low dose of collagen plus a low dose of methylsulfonomethane and vitamin C. And in the third group, they used a high dose of collagen, the same as the first group, and a high dose of methylsulfonomethane, 10 grams versus 1.5 grams in the low dose plus vitamin C. And then they tracked it. So in terms of dermal density, these are ultrasound images of the different subjects. And so the white lines to the left are the epidermis, right? Epidermis is dead. And underneath that is the dermis after a water line. And what we can see is that in all of the groups except for the placebo, which is down here, you do get a significant improvement in the density, in the concentration of the dermis when you go from time equals 0 to time equals 12 weeks. All across the board you can see that, except in the placebo. In terms of dermal thickness, the change from baseline in comparison to placebo reached significant levels for only the 2 methylsulfonomethane containing products, the low and the high dose. And that's over here where dermal thickness in the placebo group from time 6 to time 12, it actually went down in thickness. From 6 to 12 weeks, it went up in the low dose collagen MSM group, and then in the high dose it went up even more. Skin roughness was also impacted. So in the high dose collagen group, in the collagen alone group, by week 12 it had decreased by 7.8%. So collagen did help, but when you add the MSM in, the effect was almost double of the collagen only product, slightly more in the higher dose, but even at the 1.5 grams daily, you were still getting a much more of an impact in the smoothness of the skin. There's this proposed gene regulation mechanism, right? So we talked about some of the more mechanical structural parts, but it also seems like the methylsulfonomethane is influencing things at a genetic level, and regulating a selected number of genes that are responsible for inflammation, skin barrier, moisturization, as well as those involved in skin integrity, which are associated with the aging process. So this is a proposed mechanism. This is not a fact. Here is another study where people were given 3 grams a day of methylsulfonaphane. So this is a 16-week double-blind placebo-controlled study, and people were either randomized to the MSM or the placebo group. The MSM got capsules of MSM and the placebo got capsules of rice powder. What they did was a 1-week washout period to get everyone on the same page using the same products on their skin so that there wasn't any interference with that. And then they gave them either the placebo or the 3 grams of MSM a day. This is a special kind that is produced in Washington. And what happened was everyone was blind. No one knew who was getting what, the researchers or the study group. And then they unblinded the researchers in the end. They used a cutometer to measure viscoelastic properties of the skin. They used a corneometer to measure skin moisture by measuring electrical capacitance. They used a vapometer to measure the skin barrier function, to measure water loss, and they used a spectrophotometric intercutaneous analysis scope to analyze the melanin, hemoglobin, and collagen by imaging the skin with high-density light-emitting diodes, discrete wavelengths. Outcome: it did influence the skin at a genetic level, and it seems to be working by regulating a select number of genes that are responsible for inflammation, skin barrier, moisture, as well as those that influence structure and anti-aging. They also checked things like elasticity and firmness and found that those both improved as well. So again, the reason that talking about skin when this is a digestive lecture is because both the skin and the intestinal lining are barriers, right? That is one of their huge main functions, is to keep the outside world outside so that we don't get infections, because there's literally bacteria, viruses, yeast everywhere. So the skin and the intestinal lining are both epithelium. The skin and the intestine both rely on multifaceted mechanisms to maintain homeostasis and protect us against invading microbes. The components essential for proper homeostasis between the external environment and the skin or the intestine, because they're doing the same thing, from their physical barrier is included. So the epithelial cells form a physical barrier. There's a chemical barrier. They're releasing chemicals to protect us. There's a presence of beneficial commensal microbiota, both on the outside and on the inside of us. Those are our friends, our bacterial friends that are helping us. And there is tissue-resident and infiltrating immune cells, right? So there's immune cells right underneath your skin and right underneath the digestive lining that are ready to help you in case someone comes across that shouldn't come across. The barriers of the skin and intestine are not only habitants for commensal microbiota, but they also represent potential entry sites for pathogens, right? Bacteria, viruses, fungi, and parasites. So there's that argument between sort of the Beauchamp and Pasteur, right? So way back in time in France, Pasteur was the one was like, okay, we got to sterilize everything. We got to pasteurize our milk and sterilize it so it doesn't make us sick. He had a point for sure. And then Beauchamp was, we got to strengthen the inside of the body because it's always being exposed to microbes. So if we're strong, they can't get in. So I think the combination of both of these is where we are right now. So let's take a look closely at the barrier elements within the enterocyte, right? The enterocyte is the single cell that lines the digestive barrier. So they're connected together with these tight junctions, which are sulfated glycosaminoglycans, that form that strong physical barrier that impedes the translocation of pathogenic microbes or toxins. And they're sitting on a basement membrane, which again is sulfated glycosaminoglycans, and that's giving the movement that's allowed. Single cell layer thick. Your food is going to get absorbed on this end once it's completely broken down, and it's going to go through. And that food is going to be carbohydrates and proteins. Fats go through the lymphatic system. So I really want to look at this closely with you, because I think there's a lot going on here that's really helps explain how the system works. Okay, let's get orientation. So the top here, we're looking at the microvilli. Those are those finger-like projections that are on top of the cells that line the digestive barrier, right? So there's the tube, and all those little finger-like projections are sticking in there to increase the absorption surface, because you're trying to get nutrients from your food over there. So then what happens is that they're going to sit on this basement membrane, right? And the basement membrane is what's holding everything into place and giving you motility. And we know already that's a sulfated. Underneath it, we're going to have the immune system waiting to protect you in case something comes across or maybe sneaks through one of these gaps because you've got a leaky gut. So this immune system is there waiting to help you. Then we're going to have another basement membrane, and then we're going to have the endothelial cells, the lining of the blood vessels, and this is how the food is going to move. It's going to get broken down. It's going to be absorbed as individual units for carbohydrates and proteins. Amino acids and monosaccharides are going to go through. Check it out in here. Everything's safe. Keep moving. Go into the bloodstream and the portal vein and off to the liver. And the only difference with lipids or fats is that they're going through the lymphatic system. They're not going through this system. So the basement membranes are going to support and separate the epithelium from the underlying connective tissue or lamina propria, but they also influence the behavior of the cells by controlling their shape, gene expression, adhesion, migration, proliferation, and apoptosis when you need to destroy a cell. The gut basement membrane consists, as elsewhere in the body, of laminins, collagen, proteoglycans, calcium-binding proteins such as fibrillin, and various other structural or adhesive proteins. Sulfur in the basement membrane is in the form of the glycosaminoglycans, heparan sulfate, sulfonamide bonds, and they contribute to its structural integrity, stability, and elasticity. Motility. So let's talk about motility now and really get into the digestive system. So we know that disulfide bonds are important chemical crosslinks that control elasticity. But what does this elasticity do for us? It provides us with motility, stretch, recoil, elasticity, and permeability. Basically, what the whole system is designed to do, move things through the body. Sulfur has other functions as well. So the sulfur cycle is very complex inside of you. This is happening for everyone. You cannot be allergic to sulfur. Sulfur is responsible for transporting cyclic compounds in our body. So things that are ring-shaped, like vitamin D, cholesterol, tryptophan, tyrosine, phenylalanine, those are all ring-shaped, and they can't move through your body, through the bloodstream, without sulfate transporting it. So that's important. We know that there's a phase 2 sulfonation pathway in the liver, so that's detoxification using sulfate. Sulfate is responsible for DNA repair and is also protective. So this is a short list. There's a lot of other thing that it does, but as a short list, I'm going to focus in on this. Protectively, there is a research scientist, Gerald Pollack, who has discovered this exclusion zone water, or a gel form of sulfur. So water can exist in a liquid form, the water we drink, a solid form, ice, a gaseous form, steam, and now a gel form, the fourth phase of water, which is sulfated water. And what that sulfated gel water is doing is it's lining your blood vessels and everything suspended in blood to protect it. Now we're going to go a little bit further into some of the different anti-inflammatory, antioxidant properties of methylsulfonomethane. And I feel like I covered a lot of this earlier, so I'm going to go through these pretty quickly. We know that it's inhibitory of some of the inflammatory cytokines. There was a mice study where the MSM actually showed that it protected mice, and that was via these pro-inflammatory cytokines. So what they did was they damaged the mice gastric mucosa, that's the stomach mucosa, intestinal esophagus, with alcohol and HCl. And the mice that had MSM at the same time had higher levels of glutathione, catalase, prostaglandins, and decreased the levels of the inflammatory cytokines like peroxidase, carbonyl protein, and nitric oxide, which decreases that vasodilation, which is sometimes what you want. Antioxidant properties, so that was inflammation. Antioxidants, we know that there are at least 4 types of transcription factors that MSM influences, including the p53 system and nuclear factor 2. And by mediating these transcription factors, MSM can regulate the balance of reactive oxygen species and antioxidant enzymes, so downregulating some of those things that are causing oxidation in the body. And oxidation leads to cell damage, quite simply. Here's another immune modulation study where it was mice, and basically what happens is that when you exercise, this is humans too, when you exercise to exhaustion, your bacterial cells start to release these lipopolysaccharides, and those lipopolysaccharides they're not good, right? But if you pre-treat with MSM prior to this exhaustive exercise, there's less of that response happening, and that triggers less of an overall suppression of the immune system. So I'll just let you read all the rest of that. And here's something that comes up a ton of times for me in practice, is that because histamine and collagen seem to be the buzzwords right now, and if you've practiced for as long as I have, buzzwords come and go, and things get rediscovered and go away again. But right now, histamine, it's all about histamine. You can't have an allergic reaction to methylsulfonomethane, first of all. You can't be allergic to sulfur or sulfate. And we'll get into this later. I'll talk about how sulfite is what people have reactions to. And MSM is actually an antihistamine. So here's another daily dose of 3 grams, which was significant in decreasing nasal symptoms like obstruction, rhinorrhea, which is runny nose, watery or itchy eyes, nose, and sneezing. And this was significantly also impacting peak nasal respiratory flow. One of the mechanisms of action is basically decreasing inflammation, decreasing cytokines, and decreasing prostaglandins. It also decreases nitric oxide, right? And nitric oxide is going to vasodilate and allow you to be more mucousy. So diminishing the expression of nitric oxide, synthetase, cyclooxygenase, COX-2, through the suppression of NF-kappa beta, thus lessening the production of vasodilating agents such as nitric oxide and prostanoids. Nitric oxide not only modulates vascular tone, but regulates the mast cell activation. Therefore, methylsulfonomethane may indirectly have an inhibitory role on mast cell-mediated inflammation. do a little bit of pharmacokinetics. I'll just let you read that. The foods that are high in sulfur, pretty much all the vegetables, organosulfur, and then proteins are going to contain the amino acid form of sulfur. The sulfur requirements of our body, 850 to 1500 milligrams per day. We can't make it. We have to take it in our diets. So for those people who are on low FODMAP diets and they're restricting the brassica family, the cruciferous family, the allium family of vegetables, they're not getting a lot of these organic versions of sulfur that their body can use, including methylsulfonomethane. And what we know about the amino acid version is that methionine is the universal sulfur donor, right? It contains most of the sulfur that we get in our diet, and so that's coming from animal proteins. And once our body has methionine, it can make cysteine and all the other sulfur-containing compounds. We can't make biotin or thiamine, right? So those are some B vitamins. We can't make those. We have to take those in also. But all of the other sulfur-containing elements that we've talked about before can be synthesized from methionine once we have that. And then on the other end of the system, we're going to use the sulfite oxidase to oxidize sulfite to sulfate, so it can be used as a carrier protein and go into the Pap cycle. It can be excreted through the kidneys. So this metabolism of sulfur on the other end, we don't store sulfur in our body, right? So any excess sulfur-based amino acids are going to be oxidized to inorganic sulfate through the sulfite oxidase and excreted through the urine, because neither organic nor inorganic excesses of sulfur can be stored, right? Sulfur is not like calcium. Calcium we store it in the bones. When we need some, we liberate it from the bones. When we have too much, we put it back in the bones. There's that dynamic system. Whereas with sulfur, there's no storage. It's going to always be excreted, so we always have to bring more in. Sulfate is concentrated normally in the serum at around 3.5 milligrams per 100 mLs. And roughly 5 to 10% are in the form of sulfate and sulfate ions in the blood. And those are the things that you're going to find as that fourth phase of water, the exclusion zone water, and being transported out. So it's excreted in the urine as it exists in the blood. It's excreted unchanged, so there's no extra work that the kidneys have to do to get rid of it. It's diffusion, passive diffusion. And glutathione provides some sulfur that's maintained in the body. But if you look at people who have undergone oxidative stress, or animal studies where they've undergone oxidative stress, then the glutathione easily gets depleted because you're using it up. If you look at people who have been diagnosed with problems with mold or mycotoxin exposure, they're using up glutathione all the time. They're very low in sulfur, and also often they're the sensitive people that need to be titrating very slowly with their GI One powder in order to get to a therapeutic dose because they're so deficient. The MSM metabolism in the body. So this is what happens. You put it in your mouth and it's rapidly absorbed in less than an hour. Passive diffusion across the intestinal barrier does not require any transport mechanisms. Between 59 and 79% is excreted in the urine that same day. So it's moving through you and out. You're holding on to some, and it's either going to be unchanged, or if it gets involved in the Pap cycle, then it can be starting to get into the other sulfur-containing elements. The distribution is homogeneous, meaning that it goes throughout your entire body. It goes into the brain, it goes into the nervous system, it goes into all the cells and all the connective tissues. So it's a homogeneous distribution of this wonderful anti-inflammatory, immune-stimulating molecule. And that's really helpful for people who have joint pains and arthritis and things. The biological half-life is 12.2 hours, right? So basically half a day. In half a day, half of what you took is gone. And at the end of a whole day, you have a quarter left of what you took. So that's why the daily dosing is important. And the tissue distribution in humans is also likely to be widespread: cerebrospinal fluid, gray white matter of the brain. The biological half-life within the brain is 7.5 hours, so shorter in the brain than in the body. This slide is just to show you that you can't make hydrogen sulfide gas from methylsulfonylmethane, right? The way that you make hydrogen sulfide gas in the case of hydrogen sulfide SIBO is going to be the proteins and the sulfites from your diet being converted by the bacteria into those, or the breakdown of mucin and bile and taurine going into that cycle, so that methylsulfonylmethane is not contributing to hydrogen sulfide gas chemistry in the digestive system. This is the part about sulfite allergies. I get this so many times because a sulfonamide or a sulfur drug allergy is not the same as it's not the same as having a sulfur allergy. You can't have a sulfur allergy. You wouldn't be alive. In fact, there's some very rare genetic birth defects where babies are born and they don't have a sulfite oxidase, so they can't metabolize sulfur. They don't make it out of the hospital. You can't live without sulfur. So you can have a sulfite allergy, sulfite comes in the fermentation process, and for some foods, sulfite is added in as a preservative. So yes, you can have a sulfite allergy. Methylsulfonylmethane is not sulfite. There's no sulfite in the GI1 powder. Sulfite can trigger asthma, hives, sneezing, pharyngitis, abdominal pain, nausea, diarrhea. So yes, some people can't tolerate sulfite. And again, that's going to be something that's directly in the food that you're eating. Sulfate has no adverse reactions. You've got sulfate moving through your body all of the time. As previously discussed, there's no documented reactions to methylsulfonylmethane in patients with allergies to either sulfites or sulfonamide drugs taking methylsulfonylmethane over long periods of time. There's no current evidence to support concerns that methylsulfonylmethane could trigger reactions arising from sulfonamide, which is the drug version, or sulfite sensitivity or allergies. Sulfur toxicity, this is another one that I get a lot of. These are my studies showing that over the course of 3 months, at a dose of 1.5 grams per kilogram per day, showed no adverse effects, and that led to a margin of safety where they had no observed adverse effect level of 1,500 milligrams per kilogram body weight per day for methylsulfonylmethane. So let's translate into real life. If you have a 150-pound person, that person weighs 68 kilograms. You multiply 1,500 milligrams by 68 kilograms, and you get 102 milligrams per day, or 102,000 milligrams per day, or 102 grams per day. And we're talking about 30 grams per day. So you can see there's a wide margin of safety in terms of going up in your dose of the GI1 powder. Dr. Stephanie Seneff is an MIT researcher, and she's done a ton of work researching sulfur deficiency and glyphosate. And it's a big rabbit hole to get into if you look into her research, but she's got many proposed mechanisms by which glyphosate, which is Roundup, which is part of the whole GMO food manufacturing cycle, how this glyphosate, this Roundup that's sprayed on our foods, can create a sulfur deficiency for us, both by impacting the soil microbiome adversely and also by impacting our internal microbiome. Glyphosate, according to the manufacturers of Roundup study, doesn't impact our human cells, but it does impact any cell that uses the shikimate pathway, which includes 50% of our gut microbiome. And I've also listed a bunch of appendix for you for dosing Here's an amazing, this is one of my favorite diagrams in the entire world, showing how homocysteine is the feed part that starts all of the sulfur cycles and transsulfuration cycles, and then feeds into the PAP cycle so that we can make our heparin and chondroitin sulfate. Pretty beautiful. And then I've got references for you. So thank you for sticking with me through all of this. I hope it helped. And please feel free to visit my website, gijanel.com, where you can find all the information. The book that I wrote is there. My supplements are there. And then also providers who I've trained are there to assist you if you need a doctor to help you with this protocol.